accomplished panel here today, and I'd like to begin by introducing them. Dr. Adriana Fetter is the Director of Trauma and Resilience Programs at Mount Sinai Hospital and the Associate Director for Research at the World Trade Center Health Program at Mount Sinai. Dr. Fetter has conducted extensive research in the field of trauma, including clinical, epidemiological, and translational studies of resilience and post-traumatic stress in a range of trauma-exposed populations, including the World Trade Center rescue and recovery workers, earthquake survivors, and survivors of interpersonal violence. Dr. Priyanka Upadhyay, I really am so proud of myself that that I could pronounce her name. Works predominantly in a clinical capacity supporting individuals who have experienced traumatic events, most notably following the September 11th attacks. She enjoys educating patients, students, and community members on building resiliency and implementing coping skills to promote long-term well-being. And Dr. Lee Wilson, a neighbor actually of ours, not too far from our office in Connecticut, has been the medical director for the Queens World Trade Center Health Program since April of 2013. She's a board certified in internal medicine, preventative medicine, occupational and environmental medicine. She completed her fellowship in occupational medicine at Yale, New Haven in 2012. In addition, she holds a master's in public health from UCLA and industrial hygiene. So I want to welcome the panel. So I'm going to begin by asking each of the panelists to give you a brief description of their work, and then we'll proceed, with follow-up questions. So, Dr. Wilson, can I start with you?
Sure. So, I do take care of physical health issues and see monitoring and treatment programs at the Queens World Trade Center Health Program. We're under Northwell Health, formerly North Shore LIJ, before we were rebranded. So monitoring program is, we just see the first responders in our program. There's a separate clinic for survivors. A lot of police mainly in our office, some fire, construction, volunteers. The monitoring exam, do you want me to go into at the moment what the monitoring exam consists of?
We'll go into that
later. Okay.
Yeah.
So, essentially my role is I see physical health patients, but as has already been mentioned, it's really hard to separate out the physical and mental health in this population. So even though I'm not a psychiatrist, just the daughter of a psychiatrist, I do deal I deal with a little bit of both. But really my day consists of not just seeing patients, but also interpreting for other staff and for patients what does the World Trade Center Health Program offer in terms of benefits and covered conditions, and also doing audits for the government to make sure that we are in compliance with all of those things.
Dr. Fetter, how about you? Describe your work.
Sure. So I've been at Mount Sinai since the end of 2004. Although I was in New York at Columbia before when 9/11 happened. And I joined Mount Sinai as a clinical researcher, and I was doing research in mood and anxiety and PTSD. And then I started seeing, as I'm a psychiatrist, and I started seeing World Trade Center rescue and recovery workers at the center that's similar to yours, but at Mount Sinai, within the World Trade Center mental health program. I started seeing patients in 2007. And I would say about maybe 40% are police responders, and the rest construction workers, volunteers, a range of asbestos handlers, cleaners, not the survivors, so rescue and recovery workers. And then in 2011, with other collaborators, I started doing research in clinical research. So we modeled, we used information from the World Trade Center Health Program to understand the longitudinal trajectories of PTSD symptoms and what were some risk factors and potentially protective factors, comparing sort of groups of people that had very high long-term post-traumatic stress symptoms versus others who were improving over time or did not develop significant symptoms, things like that. And then now we're doing more in-depth studies, including blood biomarkers, including genetics, and also a brain imaging study. And then also one other study that I'm going to talk about a little bit later, which involves, it's an online narrative writing therapy for World Trade Center responders, and in the near future we're going to start including survivors who have still persistent significant PTSD symptoms. A clinical trial.
And Dr. Upadhyay?
Hi, good morning. I'm a licensed psychologist at the World Trade Center Health Program for the survivor community. I like to call it the community program. So this program is headquartered at Bellevue. We are the largest center, but we have satellite sites at Elmhurst Hospital and in Queens and Bellevue as well. So my role at the mental health program at Bellevue Hospital in New York City in Manhattan is primarily to provide treatment and ongoing monitoring, which is sort of, if you could think about it, yearly physicals for people and mental health assessments for folks who are members of the program. I also am involved in training and mentoring and supervision of early career social workers and staff members we have in the program. And we have now a range of psychology interns that I also supervise and coordinate the program. So like the other mental health programs across the responder side of the mental health program, we provide similar services in terms of screening, monitoring, and ongoing treatment.
Great. I wondered, once a survivor is or responder is accepted into the World Trade Center Health Program, and so it's going to be, Dr. Wilson's going to be talking about the medical conditions, and then the others talking about the mental health conditions. So what will their first appointment entail? So if you could discuss the screenings and the range of testings as part of that process.
So we usually tell people to be prepared to be there a long time on the first visit. We have people there for sometimes 4 to 5 hours. The first visit is really a data gathering event. There's a very lengthy questionnaire that the government has collecting data on onset of various symptoms that they're interested in, as well as the patient's past medical history. That questionnaire can take quite a while, and it's often difficult for folks because they're trying to recall the onset of cough, wheeze, shortness of breath, all kinds of symptoms. They're also collecting data on other medical conditions that are not necessarily covered at the present time by the World Trade Center Health Program, but it's a lengthy questionnaire. In addition, there's a breathing test, blood work, meeting with the social worker or psychologist in the office, meeting with the doctor, and so on. And if the member brings in documentation to determine if something can be covered by the program, reviewing with the provider who sees them whether that condition is supported by the documents and meets the latency and other criteria set forth by the government.
So when you're talking about medical conditions, is it helpful for somebody coming in to bring in with them records of any medication they've been on or any treatment they've had? What are your recommendations?
Absolutely. So I guess I sort of alluded to before, the government has various latency and other exposure criteria depending on what condition somebody wants to be evaluated for. Their terminology, aerodigestive, is like your sinuses, your breathing, acid reflux. For those conditions, anybody that has documentation, either of a doctor's visits or procedures, especially from 9/11/01 to 9/11/06, is the most helpful. If somebody's coming in trying to determine if their cancer is a covered condition to the program, bringing in their pathology report is absolutely critical. those are the main things that are the most helpful at the first visit.
And then
Can I
how
make
about
a
from the
comment?
mental health perspective?
So I can talk about, I just wanted to make a comment because you're mentioning the government. And so as most of you know, these programs, the health monitoring and treatment programs are funded by the government by the National Institute of Occupational Safety and Health, or NIOSH, which is a division of the CDC, which is, of course, the Center for Disease Control and Prevention. And so the purpose of these programs is actually multiple. One is to monitor the health of responders and decide who needs treatment and ongoing, what kinds of conditions have developed and will continue to develop from this event and its aftermath. Also for certification purposes, because then we, from the mental health side and physical side, it's all together. It's all one body, but there's somewhat separate divisions to decide whether if a person has, for example, PTSD or started drinking more or developed asthma, if it's directly connected to the World Trade Center rescue and recovery work. And also the third purpose is for research. And the NIOSH, the same governmental agency, also funds these research studies to try to understand, okay, so are cancers more frequent in this population? And are the cancers different? For example, those who are developing prostate cancer in this population, are they different from those who have prostate cancer who were not responders? And for that, we need a lot of data, a lot of information. So any of us doing research, really take advantage of this information that the responders come in year after year and provide and fill out these questionnaires. Now, just briefly, in terms of the mental health component, as you said, also as part of the screening at all these centers, whether it's at NYU and also for the survivors and the responder programs in Queens, in New Jersey here, at Mount Sinai, anybody who is having in the questionnaires or they report any symptoms, so they're very stressed out, they're depressed, they're having nightmares, that is taken into account, and they have the option, or if they have any financial trouble or they're really undergoing a lot of stress, they have the option to talk to one of the monitoring social workers during that health monitoring visit. And then there's a more in-depth, sort of a one-on-one conversation with a social worker. And then if there's the option to be referred for a mental health evaluation, and we call that at Mount Sinai a mental health intake. So that is a scheduled intake, and sometimes it's a more urgent intake. And so then there's a meeting with a clinician, either a psychologist or a social worker, and also with a psychiatrist. And then it's an in-depth evaluation that then is discussed privately with the mental health team afterwards. And all the symptoms and situation of the individual are reviewed, and it is decided whether there's a significant connection with the World Trade Center event or the recovery effort, and then it goes from there. I can talk about more details later.
And can you explain the difference in the survivor population or clinics?
Sure. One of the cardinal differences between the responder programs and the survivor programs is that a person comes into the survivor program expressing that they are already ill. There's a medical set of symptoms that are ongoing for them that they want to get help with. So usually there is, there are a bunch of things that have happened before we see a member at our program. They've been called, they've been vetted to make sure that they were living in the area. There's a whole bunch of sort of questions that people have to fill out before they can enter our program and even get an appointment. But the cardinal difference being that people who we see at our program have a medical issue and or a mental health concern that they would like evaluated. However, at some of the responder programs, that doesn't have to be the case. So when someone comes into our program,
we go through a similar slew of appointments and tests and evaluations because the governing body really has mandated us to be able to evaluate, monitor, and treat, and then gather data on what work we do clinically across these programs, the survivor and the responder programs. So somebody comes in, they are usually seen for a pretty long time. 4 to 5 hours is the average amount of time that someone would be expected to be at the clinic. They will see every specialty that we have at the clinic, which range across medical specialties as well as mental health specialties. And it is a pretty comprehensive evaluation targeted really to sort of assess if what the person is presenting with is likely associated to their experience and exposure on that day, and then how psychosocial stressors or stressors that just happen in life have impacted their health, their well-being, and mental health. So the first meet and greet is a screening evaluation, which is a long, comprehensive evaluation. Usually every clinic has sort of a different process of how they then take, sort of triage the needs of patients. So what we do in our survivor program is once somebody has come in for an initial visit, and there could be many trajectories. One trajectory could be the person is merely just coming in to be evaluated by specialists. We are considered specialists. And they don't want any particular clinical care. But it's always a good idea to bring in as many medical and mental health records into the program so that we know what kind of help you've gotten before or not, and what is the clinical picture we're looking at. Another trajectory can be the person is interested in either getting just certification for their medical and or their mental health conditions, because as a program we are mandated to treat certain sets of clinical conditions, medical and mental health. So our due diligence is to make sure that we are treating those conditions and not other conditions. Another trajectory can be someone is coming in saying, I was diagnosed with a particular cancer, I was diagnosed with a particular medical set of issues, or I want some mental health treatment, in which case at the screening visit, at the initial visit, someone is seeing a social worker or a psychologist, and then we have a clinical team meeting that happens every week where we review the patients we saw that week. And based on the mental health needs of the person, we would schedule an in-depth assessment called a diagnostic evaluation, where the person would meet with a psychiatrist or a psychologist. And at that meeting, we determine how much of what they are going through is related to 9/11 and their experience of it. And if not, just good clinical care is to refer somebody into the community and offer them options for treatment. If they do meet the criteria for certification, which is sort of the first step to be able to enter any kind of treatment, we would then have more of a clinical discussion with the person, which is called sort of a treatment planning discussion. It's a discussion about what the needs are, what resources we have to provide to meet those needs, if not, what is the plan, and rationale for why we think a particular form of treatment is indicated. After that evaluation is done, a person can enter treatment, can enter individual therapy, group therapy, which is something that we offer, can enter multiple modes of therapy, because trauma impacts the whole person. It doesn't impact just the mind or the body, it impacts the whole person, and the whole person is more than the sum of the parts of their physical and mental health. So we have monthly relaxation workshops that we do. We have social workers who do supportive counseling. So many trajectories are possible, but the initial visit is usually a bird's eye view of what the person needs. Can we treat them? Can we follow them? Can we justify being able to have our specialists see that particular person? The monitoring visit is really an annual physical that we hopefully all go to every year with our MDs. But the monitoring visit is akin to that. You're doing an update, but you're meeting everybody again. You're meeting all the specialties again. And sometimes it can be repetitive, but sometimes it's very informative, because a lot of what we find, I think across programs, is that people tend to develop newer conditions, or there were sort of subclinical conditions that have now become concerns that need to be addressed. So that's sort of what the monitoring helps with.
I thought I'd put a couple of World Trade Center health slides up. The one with the condition slide.
Yeah.
Oh, no, the graph. Yeah, the top 10 conditions. I wondered if we could talk about those, not necessarily having to reference a slide, but what do you see as the most common conditions in your work, Dr. Wilson, when somebody comes in and they've gone through the full screening, they're accepted into the program? What are you seeing in your work?
Conditions that are covered by the program. So it's important to keep in mind that cancers were not covered by the World Trade Center Health Program until October of 2012. And the government, again, has specific criteria about which cancers are covered through the program. Just speaking in general, certainly lots of sinusitis, as you can all imagine. Inhaling dust and as it travels through can certainly be an irritant and cause chronic sinus conditions. So certainly I'd say sinusitis is probably the biggest one. But we also have an aging population, and with an aging population, people are going to be diagnosed by definition with more and more cancer. So that's certainly becoming more common as our population ages.
And what types of cancer?
Everything. We have a lot of men, so we have a lot of prostate cancer. There's absolutely everything.
We've had some situations that people contact us, both responders and survivors, and they already have the diagnosis of brain cancer, and they think, gee, maybe this could be related to being there, and they already have their surgery scheduled. So Stephanie's able to get them quickly into the program, but I wondered about those kinds of cancers. Are you seeing a lot of brain cancer? And
at the moment, they haven't noticed. With the epidemiology that's been done so far, they haven't found that there's a significant increase in brain cancer. They have noted a slight uptick in prostate and thyroid, which is understandable. People that contact healthcare more often have higher diagnoses of those cancers because they're more prevalent more susceptible to what's called surveillance bias, meaning you're looking for it and you find it. So it's hard to say. The one cancer that they have noticed an increase that isn't well documented to have surveillance bias is multiple myeloma. So there has been a slight increase in multiple myeloma, but that's also a rare cancer. So it's hard to know if their data that a slight increase in multiple myeloma is it a real effect or not. What I always tell folks is we're watching you over time, and we have the funds to take care of people in the present day, which is really what's critical.
And early interventions when you have cancer is critical. I wonder and maybe if you could put the other slide back up, Lonnie, talking about mental health issues. If you go back, though, to that other slide, the one that you just had up, you see that post-traumatic stress and anxiety and depression are in the top 10. So I'm wondering, just from your perspective, what do you see as most common mental health diagnosis?
So we see all that, and they were very nicely reviewed by the first presenter also. So post-traumatic stress disorder is quite common. I see that you have listed this anxiety disorder, NOS, which means not otherwise specified. So these are people who do have post-traumatic stress symptoms and reactions, but they might not have all of them, but it's still significantly affecting their lives. So they might still have nightmares and disrupted sleep and feel somewhat distant from others, but perhaps they're still enjoying their life. They might have some concentration difficulties, not have the full picture, and yet they're still impaired. It's affecting their life. They're distressed by their symptoms, and so they need and want treatment. And depression is very common. It's also very common. Commonly, people who have PTSD also have depressive symptoms, sort of, feel less interested in their activities and getting together with other people. They feel down, blue, decreased motivation, and also their appetite can be affected, sometimes sleeping too little or sleeping too much, feeling tired. A number of people come in also because they've developed, they were used to being very healthy, and now they have asthma, rhinitis, sinusitis, reflux disease, and so they're having, some chronic conditions, and their life has changed. They're more limited. Maybe they used to be more active in sports, and now they're more limited in what they're able to do. So they might come in, and some of them might have developed feeling depressed because of these medical conditions, and that's something that also can be certified for. So there's a whole range of, as part of these conditions, some people have difficulty regulating their emotions, so they might become very irritable, very easily, or a bit more unhinged, have difficulty relating to others. So there's some form of therapy. Actually, at Mount Sinai, our therapists are trained in what's called dialectical behavior therapy, or DBT. And there's DBT groups and individual DBT where people who come in that have difficulty regulating their emotions, they are taught how to be more mindful and pay attention to those emotions, and instead of automatically letting them escalate, sort of they're taught some tools of how to control a little bit more their emotions. What can they do in those situations to cope?
And anything that you want to add from the Survivor Clinic?
I think we see similar trends. We have a very heterogeneous population as compared to the responder program, meaning we our program sort of tries to capture all of those folks who lived in the area, who worked in the area, who may have just been passing by, were on vacation, were staying in the downtown area for a few days. We also treat and monitor cleanup workers who came in the aftermath into the area. So we have a very varied population that we treat and sort of care for. What that implies, though, is their needs are so varied and their socioeconomic status is so varied. So we have folks who are almost earning maybe $15,000 and under per year, right up to those folks who were very affluent at one point in time but developed health problems, either couldn't work or couldn't maintain their level of working and work-life balance. So we're sort of treating all of these kinds of folks, which means then we are seeing the gamut of symptoms of PTSD, adjustment issues related to health conditions that happen and recur with every medical issue that they might be diagnosed with, more so cancer. We're seeing folks with different anxiety-based conditions outside of PTSD. We are seeing folks with chronic and persisting and occasionally waxing and waning depression. So that's very similar, I think, to the responder program, but the survivor program is dealing with just a chronic state of low quality of life combined with chronic health conditions and ongoing mental health conditions. So our treatments are really focused on treating the whole person as much as possible. So what can be therapeutic in many of our patients is being able to help them fill out, for example, complicated forms, because it is so taxing and so onerous to fill out a 75-page application for something, or even a 5-page application for some sort of assistance, that in and of itself can assume a therapy session and can be very therapeutic for our folks. So the way we really look at mental health treatment for our member community is really to meet them where they are, which means that we're focusing a lot on helping create wellness educating them about nutrition and health and mindfulness and meditation. That is done by our social workers, that is done by our psychologists, our psychiatrists. Most of us are CBT trained. Some of us are trained in EMDR. I'm trained in EMDR, mindfulness-based psychotherapy. I do some other mind-body-based psychotherapies, and we offer different ranges of treatment that are time-limited, ideally, but are flexible based on what the needs of the person are. Because it takes many of our folks come after about many years, I think. I'm doing this by anecdote, but it feels like anywhere from 5 to maybe 10 years after, when people have a decline in quality of life, have lost employment, cannot work anymore, have had personal losses. That is sort of the weight that breaks the camel's back, so to speak. That brings people in. So at that point in time, mental health treatment really assumes, I think, what John was mentioning, which is creating more of a human connection with somebody and sort of meeting them where they are in terms of their needs. So we do offer DBT-informed treatments. I'm also trained in DBT, so we do DBT-informed treatments. We do a lot of mindfulness-based education, which is sort of really being present in the moment, which really helps trauma survivors in not veering off into the past or not veering off into another state, but being more physically grounded, which is a very important toolkit for those of our patients who are chronically reliving, re-experiencing the events of that day through various triggers.
Well, and you brought up a couple of issues that we see in our work and the calls that we're receiving. People that have both medical and psychiatric conditions that are causing problems with them maintaining a job, so then they have financial problems, then they have relationship problems. But the other thing that you brought up that I think is really important, and it's something that, I talked to John a lot about, is the continued loss of life, whether it's from suicide or these ongoing funerals, that the community is so impacted by that. And so, to think about how do you deal with bereavement, because I think after 9/11, they talked a lot about trauma. They didn't talk anything about bereavement. It was all about trauma. And so, I think that's another, and maybe you see this in your work or believe, as I do, that there is an overlap. The other thing I wanted to ask about, because so much of PTSD has physical symptoms, are there things that you're seeing in your work or in the research that the PTSD is actually causing some of the medical conditions?
So there's increasing research now. There's a lot of interest, or doctors, researchers, and clinicians have noticed higher. Researchers and clinicians have noticed higher evidence of general inflammation in the body. People who have stress-related disorders, including depression and PTSD, and there's now some evidence of people with PTSD that are at risk, higher risk for cardiovascular conditions and other general conditions. And so this is an evolving area of research. I mean, one is the physical symptoms, like the increased arousal and the lack of sleep, and also changes in health behavior, like a person's tendency maybe to have some anxious eating, or not have very good sleep hygiene, or stay up very late, or have erratic sleep patterns. And all those, in addition, can actually increase the risk for other medical problems, so medical conditions. So it's an evolving area of interest, the risk for other medical conditions.
And how about substance abuse? Do you have a program to deal with the substance abuse?
We have an affiliate that we work with at Bellevue Hospital in particular that is a more addictions-focused program. Given that it requires a specialty of skill sets to treat difficulty with alcohol and or drugs, we don't have something in-house at this time, but some of our psychiatrists are trained in addictions specifically. So for those of our folks who are struggling with symptoms of PTSD, depression, and or anxiety, and have problems with drugs and or alcohol, who are not folks who would benefit from greater support, we do treat those folks on an outpatient basis. But the programs that we refer folks to are better for them if they're really struggling with addiction as a primary issue that's blocking their ability to lead lives, sort of just lead a relatively normal daily life. Those folks would always benefit from greater support, greater programmatic support, where they are involved in groups, individual therapy, dealing with psychiatrists and social workers, because addiction is not isolated even in the context of PTSD. It comes with many, many impacts on quality of life, daily functioning, relationships, losses. So it takes a village. If you were to think of addiction, it really does take a village to help the person.
And good reporting on the client's point of view, because I remember when I worked at the clinic and we would do an intake and ask them about substances, I always used to say, should I double or triple that? Because most people are not good reporters on how much they are actually drinking. But I know there's some concern right now about the opioid addiction, and do you think that's going to be one of the concerns with the survivor and responder population?
I know we are starting to touch on that in some of our medical forum calls about, should we actively address this, meet on policies and things to discuss.
And then, of course, awareness is so important in all of these areas.
Yeah, I wanted to second what you had said, because, well, there's a lot of comorbidity or co-occurrence of substance and alcohol use and PTSD and depression. And so it's a matter of degree. If somebody is very depressed or having a lot of intrusive memories about trauma or nightmares, and they're drinking excessively, but to the point where in talk therapy and meeting with psychiatrists or therapists, they're able to diminish their use and focus on the work of therapy, then someone like that can be treated at one of our programs. If the substance use or alcohol use has taken over the person's life, the person is always in an altered state of mind and is unable to process in talk therapy, or even might not benefit from antidepressant or other medications. And so in that case, some of these people even require to sort of become convinced and check themselves into a hospital in the short term to get to undergo, to treat withdrawal symptoms and go through detox. And so when the substance use condition it is really primary, as you were saying, it's important to really devote attention, whether it's opioid also, to that problem. And once that person stabilizes, there's an initial level, very specialized groups where people learn, even before trying to talk about, well, how did I get to this point? The first step is always triggers and also temptation, craving. So what do I do if I feel like I want a drink and I'm going to relapse? Who do I call? Where can I go so that I don't go to the liquor store in the corner and buy a drink? And once that stage is mastered, then there's a second or third level where people can start looking and examining their emotions. But typically, there's whole programs that are devoted to that. So, for example, at the World Trade Center Mental Health Program, if alcohol dependence or drug dependence or abuse is primary, if it's determined to be related to the WTC recovery efforts or work, then they might be certified for that condition. And that could be the person was having some drinking problem, but it sort of became much worse after 9/11. So that can be related to their work at Ground Zero, for example. In that case, they can be certified for alcohol use disorder, and then they get referred. Often we refer to St. Luke's, for example. Roosevelt has a very nice program. And so then in that case, NIOSH will cover, financially will pay for the treatment, but at a very specialty center that deals with recovery from substance dependence.
And then how about, we're going to talk later today about treatment modalities, but do you want to just talk briefly? I mean, there's so many different types of conditions that you're treating, but I don't know how you could summarize that.
I mean, briefly, I can just say, if somebody does meet criteria for coverage by the government for their physical health condition, the benefit of coverage or certification, which is the terminology that NIOSH uses, is medications for their covered condition as long as the medication's on our formulary, and we have a pretty broad formulary. Referrals to specialists for their covered condition as long as it's in the clinic's network, meaning we have a way to pay that specialist, and that care would be at no cost to the member. So I think that's probably the best thing to mention, because otherwise it would be too difficult to talk about every. What's that?
And surgery.
Right, so medical care, absolutely, as long as it's in the network and it's appropriate for that covered condition. What's interesting about this model is it's what's called a limited healthcare model, meaning we sort of take piece by piece. So if somebody's covered for the sinuses, then we can send you to see the ear, nose, and throat doctor, cover medications, nasal sprays, and so on, as long as they're on our formulary. Go ahead.
When you're done.
Oh, that's
I have a question for you.
Yeah, there's also a
It's got to
question.
be a unique question. I think that we face in the New York area where it goes from responder to survivor, where you have a lot of snowbirds, and you have people who are very comfortable being in the World Trade Center Health Program and the CCEs, but yet they leave and they go to the Carolinas, they go to Florida, and they have mental health issues, and they have PTSD issues. So they're willing to come back and fly back to come to see you, Dr. Wilson, in your facility. But at the same time, they obviously need sort of that closer to home type treatment when it comes to how do you as a facility deal with somebody like that? When have somebody that wants to come into the Northwell program, and it's not your program at all, but that wants to come into the Northwell program because they feel at home and they trust you, but yet they want to have that mental health provider in North Carolina or the mental health provider in Florida.
So it's tricky. So folks that don't need a lot of care, I'm perfectly happy to have them come back once a year, check in with me. People that do need a lot of care, we usually have them transfer the national program, which is sad for me to say goodbye to my patients, but if there is somebody that needs ongoing care, we as a CCE, which is the government's term, Clinical Center of Excellence, I didn't name us, but Matt used the term CCE. So Northwell is one of the clinical centers of excellence that the government funds. But anyway, so I'm perfectly happy to have people come up from North Carolina, but if they do need a lot of ongoing specialty care, mental health care, we can't necessarily cover it if they're out of the area. So we typically have those folks transfer to the national program.
And as much as I'm not picking on LHI, the national provider,
Yeah.
I will. They'll do that. There's a comfort level with your facility.
Right.
There's a comfort level
Yeah,
where whether
absolutely.
you're a responder or whether you are a survivor, there is sort of that, they've invested in you and they've invested in your facility, so they trust your resources and they trust your referrals. Is there anything that can be done to help you as a facility to allow them to still treat through you, but yet you have the access to refer them to mental health care, since we're here for mental health care, to refer them for the daily mental health care, because I don't think we're in telecare yet.
So I know what you're saying. So right now there are some ongoing discussions between the clinics and NIOSH about how to solve this issue. So it is in the works. Somebody over here?
In regards to, I have my condition, it's a rare condition. It's certified. I know the doctor at my program. I've known him for a long time. He's very smart, but there's not a snowball's chance that he can handle caring and monitoring the medications that I'm on. How do I get those medications paid for or taken care of through the World Trade Center program when the doctors, and he's said it to me, he's not comfortable with dealing with those medications.
Which clinic do you go to?
I go to the Staten Island program.
Okay. So each clinic has case managers. You really need to coordinate with the case manager at your program to talk about which specific medications for your covered condition should be paid for by the government, because you're such a unique case, it sounds like, I don't want to reveal any of your medical information here, but if you have very specific needs, you've got to talk to that case manager so they know that the medications that you're taking are for your covered condition. Because you're probably not on what's called our standard formulary,
Right.
but that doesn't mean that you don't need them. So they would most likely need to review your case carefully, and once they see that those medications are appropriate for your covered condition, they'll make an exception. But you got to figure out who your case manager is in Staten Island and have them advocate for you.
Yeah, but he needs to keep in mind that while you see your case manager and your case manager speaks to her or his boss, it's going to be NIOSH that ultimately makes that decision.
Right, exactly. So
whether you get that medication or not.
Right. But the case manager is the one that will advocate on your behalf to NIOSH, saying his condition is this, he needs these medications, there's evidence behind it, and we need to take care of it.
And then there's got to be a code for it.
So what John's saying is that if you need certain procedures or certain surgical things, there's medical codes that need to be in our universe, which is called our code book, so that we can pay for them. And that somebody might need to do some footwork on your behalf. But definitely, I would start with the case manager over at Staten Island. Do you live? Is that where you live, or?
Yeah.
I think you were.
Yes, I
don't want to take over your job. But I think
I'm an external certified psychotherapist providing trauma treatment. And if I was to move to Florida, piggyback, since I'm already in the program, could I treat some of those people?
If you're a provider.
I'm a provider, I'm already certified nationally, since it's pretty close to 9/11, I was asked by the fire department, will you be an external provider? And then I was asked by other programs. So I've been a provider since almost 9/11, so I'm just kind of wondering.
I'm not as familiar with how the national program works, if you have to like re-credential or be brought into their program separate from the clinics that are in this area. That I can't answer, actually. I'm just not as familiar with how the national program works, because patients, once they leave this area, are given like a United Healthcare card, and then they can go to certain clinics, so I just don't know how it works with.
But again, it doesn't matter what LHI is, what NIOSH says.
So.
I'm already providing, so I'm kind of curious.
Yeah,
They
so that's a
do
good question.
recommend. They do recommend. Well, I had a couple of patients who moved to Ohio, or far from New York, and so the national program provides a list of providers or medical centers that are covered by the national program, so you could very easily find out and see how you get on that list.
Sadly,
Yes.
more people, listen, not only are 9/11 responders, volunteers, and survivors moving out of state as they get older, they're going down south across the country. Doctors and nurses and people like you guys who treat us are getting older too. We're all getting older. And it would be good if some of them moved. And I don't see it. I don't see it lightly. Because for John Smith in Minnesota or Bob Jones in Oklahoma, who the LHI sent them to, they're not getting the same treatment as they would with the expertise of 15, 16 years here in New York. And we run into this a lot with Matt, myself, and other law firms and advocates. They're just not getting the same quality of care that you would get at Mount Sinai or Bellevue or LIJ or Stony Brook, Staten Island. Because the doctors here are trained for this. They've seen this.
Yeah.
A doctor in Minnesota who practices general medicine does not know anything about environmental diseases.
Right.
Or what triggered this person's post-traumatic from 9/11. That's fact. That's not me just spewing out stuff. I never open my mouth unless I know I'm 1,000% right. That's just fact.
So I think that opens up, though, just to answer your question first, is I know at our program we have a national program liaison. And so if at the FDNY they have somebody who's a liaison, which I'm sure they do, they would sort of be the interface between the program, the providers, and the national program at that particular location that, let's say, you move to. So I would recommend doing that, because we have done that with a few providers and with patients who've moved beyond the tri-state area. But I think what you are mentioning, John, I think, brings up an important advocacy point, which is I think related to what the first speaker said, that everyone who has on their biodata that they're a trauma therapist doesn't mean they can do trauma therapy. Because it does require a special amount of training and a certain orientation towards therapy. It requires a certain lion-heartedness to enter the work and stick with it with folks who have chronic exposure and have chronic medical and mental health conditions. So is that expertise uniformly across the country? Not at all. But from the perspective of the World Trade Center Health Program, NIOSH, and what you guys do, I think this might be a nice ground to advocate for creating an online training platform for providers across the country who would be interested in learning about environmental medicine, might be interested in learning about trauma-informed therapy. I have nothing more to say, and I sort of agree with you.
Your doctors get on planes and go to these different states where there's a hotbed.
The other thing is, and you had mentioned a little bit, that there's an interest now in telemedicine. And there's a telemedicine initiative. And for example, Dr. Sandra Lowe, Lowe, she's now the director of the World Trade Center Mental Health Treatment Program at Mount Sinai. She took over, she's been there for many years as the associate director, and she's very interested in telemedicine. And so there are still some restrictive laws. So for example, if I want to treat somebody in Florida, I have to be licensed in Florida because the person is living in Florida. But I anticipate, it's the same thing in the medical field, but over time, there will be maybe some exceptions, or no, as telemedicine becomes more common. But with telemedicine and also online, I'm going to talk about it you know about it because I told you about it before, and you help us advertise for it, but online psychotherapy study that we have. But if someone lives many hours away, but still in New York, 8 hours away in New York State, that's okay. And there are people who are unable to come regularly, and telemedicine is perhaps a good solution for that because the therapists are licensed in the same state. So it's not all there yet, but there's some options.
Let me just make an observation. It's not a question. This is what's going to happen. Your job's going to get worse. And again, I don't say that lightly. This is fact. The average age of the 9/11 responder was about 39 years old on 9/11. That's average. So now you're seeing 55, 56, 57 years old. With age, that just sucks. You get older, it hurts. Now add these illnesses, it makes it even that much worse, which already makes your job more difficult. But we didn't even mention the asbestos cancers that are coming. And that takes a 20-year manufacture on average. We're on the cusp of that. And I guarantee, how many people are at ground zero? Raise your hand. 1, 2, 3, 4, 5, 6, 7.
And then the gentleman.
Three of us are going to get asbestos cancer. So just take that to the population now. And then when you get that, even those who do the mental health, that's going to spike. Why am I getting cancer at 63? I thought I got past all my other illnesses.
Absolutely.
This is only going to get worse. Right now, what we see is spike in skin cancers and other cancers, and skin cancer is number 1 now. There's a new cancer coming, and it might not kill you right away, but it is a debilitating, agonizing, painfully way to die. And this is coming.
Well, and John, you brought up such a good point about the expertise that the World Trade Center Health Program has. And these 3 individuals are some of the many who have made this their life's work. And it's so critical, I think, to document that work, to continue to not just to provide services, but conduct the research where we'll learn from it. Because although many of these other events, and I understand there was a shooting just this morning in Texas, when a community is impacted, they can learn from us, having worked with a very large community. And, I can't say enough about the people that are doing the work in these clinics, and what a pleasure it is for John and I and the other groups to be working in that outreach program, and working very collaboratively, both with our outreach, other outreach partners, but also with the clinic. So thank you very much for your work, and thank you for being here today.
Can I ask one question? So far, you've spoken about rescue workers, and you've spoken about survivors in the downtown area. Is there anything available to family members who are outside the downtown area, such as a child, a teenager on 9/11 who is now an adult child, who is now everything surfacing and has problems, and is, his life is definitely impacted.
The STAC committee is looking into that.
I'm sorry?
The STAC,
The Scientific
Technical
Advisory
Committee is looking into that now. Listen, John Smith, the cop who worked at Ground Zero, went home. His wife washed his clothes with the kids' clothes, or whatever the case may be. Or Daddy came home in Hus Jr. This is a serious issue. It's being addressed. How far it goes after the STAC committee, we don't know.
What I'm really focused on is the mental health.
Mm-hmm.
All the symptoms in my family's case. He's got it. The PTSD, the anxiety, the panic attacks, the inability to work because he can't focus.
The kid's depression.
29
the kid's
years old.
addictions.
So is there anything to survive? Obviously, you two are mostly focused on rescue workers, and you're survivors at Bellevue, but is there anything, could family members be able to be in your program?
I think that's something that we have always bumped up against as being an issue, because we really treat those folks who were down there that day. But it is, I think, sort of difficult to assume that family members will not be affected when the person who was down there and survived goes back into their family. So at this point in time, what we do when we encounter someone who comes in, let's say with their young adult, 22, failed out of college, can't go back, is not working, is they go through the process of meeting those eligibility criteria to come into our program as a member of our program, as a patient of our program. But for the family members, we have social workers who might, talk with you and find, for example, if you're coming with your loved one.
Well, the loved one deceased. So it's a teenager,
Yeah. Who
lost her
13-year-old
parent.
back then,
Yeah.
who's now 29, and
Yeah.
for all these 17 years, everything was, buried, and
Yeah.
now it's surfacing as a 29-year-old.
Yeah. What services are available for children who lost a parent?
Really disabled.
So I think at this point in time, the center at Bellevue does not have direct clinical services, mental health services for family members of those who belong or would belong to the
Yes,
survivors.
there's a lot.
Children has lots
you're
of
not
family
aware of it?
programs.
But I think there are community organizations that I'm not aware of that maybe folks here will be aware of.
Voices of September 11th.
They do.
I think there are community
I can
partners.
talk to you off the, after the
Catholic
event. I can talk
Charities,
to you about
PEG.
that.
But I think if the program has been renewed for 75
But we really
years,
have
Yeah.
to work.
Go ahead.
that's the next
40 minutes
step. I
past
think
the-
it's important.
You're going to have time to ask questions.
No, it's a follow-up to what she's saying. 'Cause
Okay.
my understanding is that in certain certified illnesses, that family members have been eligible for mental health care. Because I have responders who have cancer that are treating in both of your programs who have younger children. And actually, the pushback has been from them has been that they have to come into New York City to get it. I just know that from these families, that they have been granted certain mental health services for their children when it came to the person with the certified illness. I don't have anything more than that.
That's
I'm
with a
sorry.
responder, though, a responder who is a certified illness, and the children of that responder, is that what you're saying?
In this situation, they are responders. That's the little information I do know.
Well, maybe we could, we're going to be going downstairs now, and we're
Okay.
going to have some peer-to-peer network where we can talk, and then we'll have lunch, so you can ask questions of individuals, because you're going to be here all day, correct? Yep. But I can talk to you directly about that. Thank you.
As an external provider.